Okay, let's just dive right into this critical explainer because this one, it's designed specifically for you, emergency physicians facing the absolute high-stakes reality of neuroinfections. Look, when it comes to acute bacterial meningitis and viral encephalitis in adults, time is brain, right? Time is survival. Literally every single minute that ticks by in the ED without definitive action just drives up morbidity and mortality. So today, we're going to break down the latest guidelines from the European Society for Clinical Microbiology and Infectious Diseases, the Association of British Neurologists, and frontline NHS protocols to really streamline your clinical decision-making on your very next shift.
So, picture this. A patient rolls through your doors. They've got a fever and altered mental status. The triage nurse suspects a central nervous system infection, which is a great catch. But before you anchor on textbook presentations, waiting for every classic symptom to magically appear before you take action, we really need to ask ourselves a crucial question. Just how reliable is that classic triad of meningitis we all spent hours memorizing in med school?
Well, here's the reality check. That classic triad, fever, neck stiffness, and altered mental status, it's actually only present in 44% of patients. Yeah, less than half, according to Netherlands cohort data analyzed in the ESCMID guidelines. Think about that for a second. If you're waiting around to see all three symptoms before triggering your severe infection pathway, you're going to delay treatment for more than half of your bacterial meningitis patients. That's huge. Having a really high index of suspicion based on a partial presentation isn't just a good idea, it is absolutely mandatory.
Here is our roadmap to mastering the golden hour. 1. The diagnostic dilemma. 2. The golden hour workup. 3. Life-saving empiric treatments. 4. Managing critical complications. And finally, 5. Key take-home messages.
Okay, moving into Section 1, the diagnostic dilemma, recognizing the threat. So the absolute trigger for empiric acyclovir is recognizing altered mental status. It's a critical distinction. If a patient presents with just meningitis symptoms, like they've got the headache, they've got the fever, but their consciousness is completely normal, acyclovir actually isn't indicated. But the very second you detect altered consciousness, we're talking disorientation, lethargy, any behavioral changes, you've got to suspect encephalitis. That right there is your clinical pivot point for starting immediate empiric IV acyclovir while you wait for confirmatory testing. We really don't want to reflexively hand it out for simple viral meningitis, but man, we absolutely cannot miss it if it's encephalitis.
And that brings us to a major myth bust from the ESCMI guidelines. You absolutely cannot safely rule out bacterial meningitis just because Koenig or Brzezinski signs are absent. The evidence is super clear here. Their sensitivity and negative predictive value are, well, alarmingly low. So please, do not let a supple neck or a negative leg extension test give you false reassurance if the overall clinical picture is screaming severe CNS infection.
All right, Section 2, the golden hour workup, racing the clock.
Okay, this is your exact chronological game plan. Step 1, get your blood cultures and gases immediately. You have to do this before any antibiotics touch the patient. Step 2, if that lumbar puncture is going to be delayed by more than an hour, which, let's be real, often happens because you're waiting on a brain scan, you must administer empiric treatments right then and there. Step 3 is your cranial imaging, if it's actually indicated. And Step 4 is the LP itself. The absolute golden rule here, never, ever let the logistics of getting a CT scan or an LP delay the delivery of life-saving empiric antimicrobial therapy.
Speaking of imaging, let's talk about the CT scanner, right? It's the classic ER bottleneck. You only delay the LP for a CT scan if your patient hits one of these exact criteria: focal neurologic deficits, new onset seizures, severely altered mental status, specifically we're looking at a Glasgow Coma Scale score of less than 10, or a severely immunocompromised state. If your patient doesn't check any of those specific boxes, ESCMID guidelines strongly recommend against cranial imaging before the lumbar puncture. Just proceed straight to the TAP.
Now for Section 3, life-saving empiric treatments, decisive action.
Okay, this is a grade A ESCMID recommendation that you literally cannot ignore. Antibiotics must be administered within 1 hour of arrival, period. Delaying treatment is directly tied to poor outcomes. So even if your diagnosis is unconfirmed or the LP is held up because the CT scanner is busy, you have to start empiric treatment immediately based purely on your clinical suspicion.
Let's lock in these numbers for your empiric dosing. Keep a mental checklist of this. For suspected bacterial meningitis, you're going with high-dose ceftriaxone. That's 2 grams IV every 12 hours. To tackle the inflammatory response, you want dexamethasone, 10 milligrams IV 4 times a day.
And if you're suspecting viral encephalitis because of that altered mental status we talked about, you're hitting them with acyclovir at a weight-based dose of 10 to 15 milligrams per kilogram intravenously every 8 hours. Now, major pitfall alert here regarding corticosteroids. Dexamethasone is incredibly effective at reducing long-term neurological damage, like hearing loss. It does this by dampening that massive inflammatory response that flares up when antibiotics lyse the bacteria. But, and this is a huge but, you have to administer the dexamethasone prior to or at the exact same time as that very first dose of antibiotics. If you give the antibiotics first and just kind of wait to see how the patient does, well, you've completely missed the window to prevent that initial devastating inflammatory cascade. And this stat right here is exactly why we hunt so aggressively for altered mental status. Hitting a patient early with IV acyclovir for herpes simplex virus encephalitis, it drops mortality from a terrifying 70% down to 20 to 30%. That is a massive difference. Delaying this medication beyond 48 hours is associated with a drastically worse prognosis. Like we said earlier, time is brain. Moving to Section 4, Managing Critical Complications, Post-Resuscitation Care.
So even after the meds are on board, things can go south quickly, so be highly vigilant for acute complications. You need to actively delay the lumbar puncture and immediately get the intensive care team involved if your patient develops respiratory compromise, signs of raised intracranial pressure, or frequent seizures. If their GCS drops below 9, strongly consider securing that airway with intubation and keep a super close eye out for a rapidly evolving petechial or purpuric rash, which points straight to meningococcal septicemia. These patients are going to require immediate critical care escalation, targeted oxygen therapy, and really aggressive seizure management.
Let's wrap up with Section 5, Key Take-Home Messages, Clinical Mastery. All right, here are your 5 non-negotiable takeaways to bring to the bedside. Number 1, expect atypical presentations. That classic triad, it only shows up 44% of the time. Number 2, target the altered mental status. If they're confused or lethargic, start that acyclovir. Number 3, strictly triage your CT scans. Don't image before the LP unless there are specific red flags, like a GCS under 10 or new focal deficits. Number 4, never miss that 1-hour medication window for antibiotics. And number 5, always remember, dexamethasone must precede or accompany that first antibiotic dose. So, as you head into your next shift, I want you to really look at your local workflow and ask yourself a tough question. When that next undifferentiated encephalopathic patient rolls into your resus bay, are you and your team truly optimized to beat the clock? Do you actually have the systems in place to get blood cultures drawn, DEXA and ceftriaxone hanging, and acyclovir running all within 60 minutes? Because if not, it might be time to champion that change in your department. Thanks for joining me for this explainer, and stay sharp out there.